So thanks everybody for joining us. We found that there is kind of a deficit in trying to get trainees to understand the curriculum, but also get some teaching on the shop floor, especially in the emergency medicine trainees. So we thought we would just help them out by doing some Saved by the Probe ultrasound education series, and we lined up a few talks starting from ACCS EM trainees, but also for higher specialty trainees and maybe even quite educational for some consultants. So first of all, I'd like to introduce our first talk and speaker. Thanks, Nick, for agreeing to do this. But for those who don't know, Nick Mani is a emergency medicine consultant and also a very well-known POCUS educator. And if you're attending the RCEM ASC conference in 7th, 8th, and 9th October, you will see him with the ultrasound probe doing what he does best. He was also the co-chair and the lead for RCEM POCUS Education and Training Subcommittee and created the 2021 competency-based POCUS syllabus that we now follow. He's also the editorial board of the BM Ultrasound Journal as well as the USEM Emergency Medicine Journal. He also is the co-founder and the editor-in-chief for POCUSUK.org. And anybody who doesn't know about this website, I would quite urge you to have a look when you can. I also have had some privilege to contribute to the website, but it's been great working with Nick on this kind of project. But also, he's also a supervisor, mentor, and trainer in POCUS across various specialties, from acute medicine to emergency medicine. So I thought, why not have Nick actually speak about the document that he has kind of worked so hard to produce, and also give us an overview of POCUS curriculum, which might be more relevant to emergency medicine, but also help with kind of clearing out certain doubts, and also maybe open a door for other people who want to pursue and get accredited in point of care ultrasound. Take it away, Nick.
Okay, thank you very much, Google. Good evening, everybody. I'm here to talk about the point of care ultrasound curriculum, and I'm going to try to hopefully make it very simple for everybody, and I'll be happy to take any questions. So I'm going to touch a bit on what was there in the curriculum and what it is that we're going to follow now, and I'm going to predict what could be coming in the future as well. So I'm not sure how familiar you are with this pathway, the level 1 curriculum for point of care ultrasound that we had. It came about in 2010 when point of care ultrasound was officially introduced into the emergency medicine curriculum. And as with anything else, there were some strengths and weaknesses with it. And I think as it transpired, it sort of didn't really fit what it was envisaged to do, because on paper these things can look great, but in practice, especially if you're asking everybody to be doing this as a part of the curriculum, it can become challenging, and it can start becoming a tick box exercise. And we've certainly seen that when we've got first day consultants who are not confident, but they needed to get this signed off in order to become consultants. And that's a shame, because that's a missed opportunity. But in some ways, you have to look at the system and how it was set up. And perhaps when it was set up at the start, it was fit for purpose, but it sort of outlives itself, and particularly with competency-based curriculums that are coming along for not just the ultrasound. We've actually been the first ones to put point of care ultrasound through that model, but competency-based curriculum is something that's been around for some time, and it is part of many curriculums. And I think in some ways we've been slow to catch up to it. And I'll go more into it. So this is, as I say, this is what we used to follow. Now, if you look at the more recent EMTA survey, what transpires is that most departments do have a machine of some sort. However, the challenge is the supervision. And certainly when we had level 1, there was some guidance as to who can be supervisor, which, you know, in some ways it was a guidance. And what we've tried to do with the new curriculum is to learn from those lessons and to ensure that we make it much more accessible to the trainees, even though I understand it's not always possible to achieve that, but we had to change something because the previous model wasn't working. And equally, General Medical Council had this document, which is a recent document. I'm not sure if anybody has seen it, but it was a guidance in terms of what had to be in the postgraduate curriculum. Every 5 years, all the specialties have to review the curriculum, and they need to use the guidance of GMC to update it. And in some ways, it's a great opportunity to be able to change the curriculum or introduce new aspects to it. So as you can see, there are lots of different factors that involved with curriculum, and it's not just as easy as introducing certain aspects that we want those enthusiasts want, whether not just with ultrasound but with anything else. And certainly we've seen that, I'm not sure whether you know that, acute medicine has just introduced point of care ultrasound into the official curriculum, and it used to be a standalone, as it was called, famous. Now critical care has been trying to do that for the last 10 years, and for various reasons they've not been able to do that, so they're still running it as a standalone. And still, it seems to me that they are following a numbers and tick box exercise, and it's not going to be fitting the GMC sort of guidance, even though, as I said, the acute medicine have managed to get it in the curriculum. And I think that they have tried to, on paper at least, show that it is a competency-based, but I think in practice, a lot of trainees will be still following famous rather than a competency-based model. So you might ask, well, what is a sort of a competency model? What is it that we're trying to achieve? Well, it's about starting trainees on a journey right from the start to the end. And it's a spiral sort of journey. You start with the basics and you keep building up on that slowly. And that allows you to incorporate it into your clinical practice rather than being a standalone competency, as it were. And it shouldn't be any different to anything else that we have in the curriculum. Whereas the previous model, it felt very much like a tick box exercise, where it didn't feel like a journey, certainly. And as an example, there were trainees who were coming to ST5, ST6, and you found that they were struggling to get this signed off, so they used to go to the so-called finishing schools and paying out of their own pockets to get this signed off, and they hadn't really gone on that journey. So the competency-based training allows the trainees to build themselves up slowly from the start of the training right to the end of the training, and then hopefully they can continue that journey after that too. So that's the sort of the long and short of it, really. It's a spiral curriculum that runs alongside and parallel to everything else, and it starts off with basic, and it gets more and more complex and more advanced, as it were. I know this is a busy slide, but just as an illustration, in terms of what we're trying to achieve, is that we're trying to achieve competency, experience, and confidence of the trainees, so that they're moving up that ladder from being a novice to an expert, and they have evidence to show they are moving from point A to point B. And it's not about sort of jumping in between those 2 points. It's much more like a journey, and it's about showing that you've done various different activities, in which I will go into in more details, in such a pace that it feels that you've been proactive, you've learned, and you can certainly, as a day one consultant, you're able to practice this competency safely, as is any other competencies that you're expected to gain. And don't forget, this is not just point of care ultrasound. Is not just it's not just, some people might see it as it's a gadget and it's fancy and so on and so forth. I think you really need to understand it before making these passing comments, because I've come across few people who have made these passing comments. At the end of the day, this is to help the patient, and is to help the patient care and safety. And as long as you understand that and you respect that, this is no different than obtaining ECG or venous blood gas or chest X-ray and so on. This is an extension of your standard clinical assessment, and it's certainly not meant to be a departmental ultrasound. It's not certainly meant to be replacing CT scans or any other sort of assessments. It's meant to be a part of the puzzle for you to be able to build a picture. So I hope you've come across this RCEM entrustment scale, which goes throughout the different competencies and components of the new curriculum. And the idea is that you're on a journey from entrustment scale 1 to becoming independent. That is entrustment scale 4. And this idea of being signed off, which used to be perceived as, I've got a piece of paper that I've signed off, so now I'm independent. It certainly felt like somebody was jumping from entrustment scale 1 to 4, and that in between steps were certainly blurred. What you got to remember is that competency is, when we're talking about competency levels, you can be competent, but that competency could be at different level. So you could be competent when you're performing a procedure, or you're performing point of care ultrasound with a supervisor who is immediately available, and that can be defined as a competency. So you're competent at that level, or you could be completely independent and competent to perform point of care ultrasound in such a way that you don't need anybody else. However, you still do recognize the limitations of that scan. So hopefully you recognize that competency is not just the binary term that I'm either competent or I'm not competent, but rather the competency of one is at a certain level. So I hope that makes sense to you. So moving on from that then, based on that, we've sort of, as a guidance, we've come up with a stage of training and what we envisage trainees to gain as they're going through the journey of the training. And I hope that you can see how it's been built up from the basics of point of care ultrasound, which is important to lay that foundation, right away to then more complex, advanced scans, which is the hypotension protocol, which incorporates all the scans together in 7 minutes in order to be able to help assess a patient who's presenting with hypotension. So this is just a guidance, but what's important to recognize is that you can't just leave it all to the end. You have to be using the opportunities that you get throughout your training to get the competencies that you need and get that evidence. And also, you can't just park it. You have to continue showing that, for example, once you become entrustment scale 4 in abdominal aorta scan, you have to show that you're keeping that competency. So that is important to note, because if you don't, then you will start getting rusty. Now, in order to get these, you need to, of course, you need support and help, and that will come from the departments that you're rotating through. It's coming from the college tutors, your educational supervisors, the training program director. There could be a regional or a departmental lead for point of care ultrasound, and also head of a school and the college. I understand that it may sometimes feel that it is a bit disjointed, but certainly that's not the intention. And some of it does fall onto the trainees. We do need to be proactive. We are adult learners. However, there are different pressures within the system. And when you are rotating through acute medicine, you can gain some of these competencies through some of the supervisors that are there. Or if you're rotating through anesthetic, if there is a neck of femur list, for example, you can be getting competent in performing fascioiliac compartment block or ultrasound guided access. Critical care is no different. You can start performing scans, hypertension, different aspects of the hypertension scans, for example, the echo part of it, and get really comfortable looking at the heart. And sometimes it's in fact, most of the time, it should be starting by looking at the normal and realizing what is normal. It's a bit like going back to medical school and looking at when we started examining, when we learned how to do clinical examination, we started examining each other and we recognized what was normal and we got really slick at it, and that was our reference. So it's very important to recognize what is normal and then hopefully start building up on that. And when you see something that's abnormal, you then recognize it. Even if it's very complex, you do recognize that's abnormal, and that in itself is important. So you might ask, well, how do I sort of put it all together? As you know, previously, the way it worked was that you had to go on for emergency medicine, you had to go on a level 1, so-called level 1 course. And then after that, you had to sort of do certain number of scans of each modalities. You had to do certain reflections, then do triggered assessments and get signed off. And it seemed like a very rigid, kind of disjointed almost, and there was various issues with it. Whereas what we've said now is that, you know, this is down to you to be able to put all these evidence within your portfolio, not right at the end when you get to ST5 and ST6, for example, but actually try to do it as you're going through the different rotations. And the 3 different aspects of it is, one is going to study days. Doesn't have to be courses. It can literally be a local or a regional course. And this doesn't have to be specific to emergency medicine. It can be going to one that's run by acute medicine clinicians, or it can be one that's run by the critical care clinicians. And you know, it's not, these study days are not rigid. It can be anything. It can be simulation. It can be a number of things. You know, the most important thing is that you do continue to go on these study days. I don't personally think it's enough to go on just the 1 or 2 days of a course or a study day. You need this support right throughout your training, and you need to look for opportunities. The deanery should be giving you opportunities too, as well as the departments. So this is to do with that kind of taught aspect of it, if you like. And once you've sort of, that's one part of it. The other aspect is to do with assessment. And assessment doesn't need to be formal or triggered assessment or so on, and it doesn't need to be a standalone one. It can be part of, for example, when you do ACAT or ESLI, it can be as a part of that. For example, when you're seeing one of the patients as a part of that, you might be wanting to perform point of care ultrasound to assess, for example, abdominal aorta. Equally, it could be case-based discussion and so on. Now, the simulation is becoming more and more important, as you know, and I think one of the aspects is to recognize that incorporating point of care ultrasound is important to see the bigger picture and how it can integrate into the kind of the assessment within the whole team. And certainly I've seen that working really well if the scenarios are put together really well. For example, echoing life support, or in a patient who is shocked. That might be some examples. And it doesn't need to be a summative assessment. It can be accumulated over time. And the other aspect of it is to do with your own reflections, your own sort of collecting the scans that you've done. And there shouldn't really be any rigid numbers, because if you look into the literature, there isn't any evidence to say that if you do 10 scans or 20 scans or 100 scans, then you reach that competency. Everybody is at a different level. For example, if you do remember when you learn to cycle, for example, it could be that your brother or sister or a friend learned to do this, to cycle a lot quicker than you, or slower than you, or at the same rate as you. Point of care ultrasound is no different, so we can't just put a number on it. You know, rigid numbers are not particularly helpful, and we've seen it in practice. There are learnings that you can do. Image library becomes important, and certainly We've tried really hard as a part of POCUSUK.org, which is a website we've created, free open access medical education, where we have cases that you can see the abnormality. And as I said, it's important to know what normal is. So you have to really get your eye in as to what normal is. And then when you see the abnormal, you can spot that. And all of this needs to be collected in your portfolio as an evidence. And when you have the ARCP, hopefully, if the school or the region has got a point of care ultrasound lead, they can help the TPD and the head of the school to go through these, and they can also keep you in check, so they can give you feedback and say, actually, you might want to focus a bit more on certain aspects for the next time. And obviously, this is just one aspect of the curriculum, of course. So this is not all the aspect, and it shouldn't really be done in any separate way. Now, we were pressed by various people to put numbers of the scans in the curriculum, and note that these are not rigid numbers. It's indicative numbers, and reflection notes again are indicative. So as I mentioned before, if you're doing more or less of the scans, the most important part of it is that you're competent. And within the new curriculum, the new bits that we've introduced is the shock assessment, fascial block, and what we call FAF, so focus assessment for free fluid, for example, in ruptured pregnancy. So it's not, as you know, FAST is essentially the same as scan, but you're looking for free fluid in the context of a patient that's not been in a trauma. So as you can see, then there are various different things that can help you. We've created guidance within RCEM website. RCEM Learning as well is getting more and more resources now up there for point of care ultrasound. You can have your own logbooks. We've got examples of that on POCUSUK.org. There are some out there already. There are websites like POCUS Atlas and various other ones where they have examples. Obviously, there's YouTube and Google and so on. So it doesn't need to be rigid. This is a learning journey that you're on. And you have to take some of that responsibility to be able to get yourself competent. So what does the future holds? Because I predict that within the next few years, we have to come to another review of the curriculum. I think firstly, we need to get this idea across that the point of care ultrasound is not a standalone exam. It's enhancing your a standard clinical assessment. So you will still doing a focused clinical assessment as you normally do. And you have a pretest probability of whatever diagnosis it might be. And it might just be that with ECG, VBG, and various other scans, including point of care ultrasound, the likelihood ratio changes and the post-test probability will change for a particular diagnosis. So as an example, if you're suspecting somebody has got a massive PE and they are hypotensive because of that, you perform point of care ultrasound and you can see that the right side, the right heart, there is evidence of right heart strain. They might have a proximal DVT. Then obviously that will move you to post-test probability, very high post-test probability. You will, of course, need to be careful and see if you can optimize a patient to take them for a CTPA to confirm that. And then there are other scans that might be coming through, such as focused echo, much more. We do have some aspects of it already in the shock assessment. There is a transosovisual echo, especially in cardiac arrest, which I suspect might be coming in more. Renal, hepatobiliary, pediatric emergency medicine is certainly underutilized in terms of the point of care ultrasound, for example, for limping child or for testicular torsion, lung ultrasound and various other things. And then we can have various different regional anesthetics. Of course, we've got the fascia iliaca compartment block now, but you might have come across the serratus anterior plane block or arterial spina plane block for chest injuries, rib injuries, which I'm sure you've seen quite commonly. And these might be single shot blocks or insertion of catheter, which can really help the patient as a part of the whole care pathway that we might the different departments might have for chest injuries. So I hope this was a useful run through the new curriculum. In summary, it's competency-based training is not actually meant to be making it more challenging for the trainees to gain the competencies and experiencing the confidence. If anything, it's there to make it much more accessible and inclusive, and make it fun and part of a journey in order to gain point of care ultrasound competency. And I understand that we still got a long way to go, but I hope that you can see we are trying to make it equitable. We're trying to make it professional. We're trying to make it sustainable. We're trying to sort of resolve some of those previous challenges and conflict of interest and various other things that went on with the level 1 ultrasound model that we had previously. And we are in some ways trailblazing, because there's not been any other accreditation out there that's using competency-based training. But I wouldn't be surprised if we are moving, if the rest of the accreditation will be moving towards this. And I've put a QR code there for any of you who want to access the guidance from that was created when I co-chaired and co-led RCEM Point of Care Ultrasound Subcommittee. And that has got a frequency asked questions, as well as for each scans that we've just mentioned. It's got a bit of a guidance as to what counts as intrasement level 1, 2, 2A, 2B, 3, and 4. So that might help. One of the other initiatives that we did run when I was still part of RCEM was Train the Trainer, and that was to help the supervisors to get more confident in order to support the trainees. And that has had various success. It's not, since I left, I'm not quite sure how sustainable it's been, and I'm hoping that that would come back. So then, as it was mentioned before, I'm going to be at the RCEM Scientific Annual Conference for the 3 days from 8th to 10th on the Sonoside stand. And these are some of the kind of, I tried to come up with some cutting edge topics to go through. One is that you might have heard of is VEXAS, which is the congestion sort of scoring system, and transosovisual echo in life support, which I did mention that it is coming in more, as well as chest blocks for rib fractures. So if you are going to be there, come and see us. I'm also on Twitter and various other social media platforms, and please visit the website as well, pocusuk.org, to go through some of the cases. And if you want to contribute please let us know, and we'll be more than happy to do that. So thank you very much. I'll be more than happy to take any questions.
Thanks, Nick. That was a quite comprehensive run through of the curriculum, and also the competency-based model, which sometimes it gets difficult for me, at least, to explain the way you did to some people who come up to me and say, "What's the new curriculum? How do we go about getting signed off?" And then when you hear signed off, and then you try to explain to them, there's no sign off, and it's the journey that you've either started now, or you're somewhere in the middle or towards the end. It's something for you to figure out, but also there are people to help you. So that was pretty cool. Unfortunately, I have set up the chat. Yeah, okay. So I had a few questions. There's none in the chat, but if anybody wants to unmute them or ask questions, just feel free. But one question I wanted to ask was, how does the competency-based model, which came out in 2021, look for in terms of like how there are a group of consultants, there are a group of senior registrars, and there are also junior trainees who obviously have started with this curriculum, and it's easy to get hang of. But about the consultants who've come about to become consultants before ultrasound was part of the curriculum, and also how does it look for senior trainees who are just almost at the end of their EM training journey, but probably not at the end of their focus and competency journey. And what some of the things, I mean, you touched upon it about teaching the trainers, which was I found, I mean, I've heard and got reviews about it. It was really great. But what are some of the things that these groups of clinicians or consultants and senior registrars can do, just to be on that journey as well?
I think in terms of consultants, it can be challenging in the way that it really depends on the consultants themselves, really, and it does sort of come down to the college to create or to have study days, and also part of conferences and CPD days, and have these have POCUS as a part of these, to encourage the consultants to come on board with it. But it is challenging with consultants because the way the appraisal and the revalidation is set out is in some ways, is in certain ways that may not always encourage the consultants to pick up certain competencies. And that's not just with point of care ultrasound. I'm sure you've seen some consultants who do procedural sedation still with midazolam and morphine, for example. You know, this is not any different. And as soon as you mention propofol and fentanyl or alfentanil or ketamine, or mixing ketamine and propofol, then they want to leave the room, for example. So this is no different, and I think it does come down on individuals, and it does come down on professionalism, but also it comes down to the culture and the of the department that's created. So within the department and within our own speciality, it's that what kind of a culture is being created, and what do we want to be, what identity do we want to have as a speciality in the UK. So from consultant side of it, it can be tricky. I did mention that, I think the trainer, it was an initiative that I came up with. I thought it was received really well because it was a platform whereby there was no assumptions that was made. Everybody was welcomed, and we had a really good uptake. It seemed that everybody enjoyed it, and there was a good feedback. And I think that there needs to be more investment in that, clearly. And there was some complaints that, well, why do we need to pay for that if this is to help the trainees? And that's kind of short-sightedness from some of the consultants. rather than seeing that as a way to develop themselves. They were seeing it as a burden, and they were seeing it as if they've been sort of it's been covered up so that they learn it in order to help the trainees to get the competencies. I'm not sure if that makes sense or not. But there are pressures within the system, and I think we are, emergency medicine is still a younger specialty, and we are still evolving. If you think about it, started as a sub-specialty of surgery, and then it sort of moved away, and it's forming its own now. I think we just have to allow time for it. I'm not sure if that sort of answered your question from the consultant side of it, but it basically, in short, it's challenging, and I think there needs to be multiple innovations and interventions that will capture that. But I don't know who can do that. So that's from that point of view. Now, from the trainee point of views, again, some of it is similar to the consultants, but I think the advantage is that the trainees still are dictated by following the curriculum, and they are sort of judged on that, rather than being this open-ended sort of revalidation and appraisal that consultants have in any specialty. So in any specialty, the consultants are not judged by the curriculum of the specialty that they have, but they're rather judged in a generic way that GMC is set out, and that might be a fault within the system. But with trainees, I understand, again, there's a pressure because of personal commitments, professional commitments, and so on. Some folks might be dually accredited, doing dual accreditation in critical care, for example. I understand, and there are pressures within the system. I think that the main thing is to create that culture within the department, have a lead, have these sessions that you've created to ensure that we're making it as clear as possible. We are supporting the trainees, and get across that actually we're trying to help, and we're trying to make the training enjoyable, because what's worse than just coming to a shift and doing what you need to do, and then going home and just ticking a box and so on. It's about making that, bettering yourself, helping the patients, rather than ticking boxes and getting things signed off, even though I understand, sometimes, that might be the case. So it's not easy, but we have to try. We have to try to create that culture. And this is not just with point of care ultrasound. As I say, there are different aspects that we have to get across.
Thanks. And just touching upon the culture, is there certain things that you've seen in some departments that have done well to bring about a culture change in regards to ultrasound, obviously, or something that you think other departments can learn from or replicate to bring about this culture change?
I think one of the or a few examples that I've seen or I've sort of initiated myself are things like ensuring that it's incorporated within the rest of the education. So, for example, if there's simulation going on or there's a schedule for simulation, try to work with whoever is running the simulation, is in charge of the simulation, and try to incorporate point of care ultrasound aspects within that. So it doesn't need to be focused on point of care ultrasound, but certainly if it is part of that, that can help. The other things are point of care ultrasound clinics have regular sort of drop-in sessions, and having regular sessions in general, and ensuring that it's a safe environment, and probably dividing that up between different tiers of trainees, because if I find that if you mix the consultants and the trainees together, then that might not work really well. But having dedicated sessions for different tiers of consultants, and also remember that there are ACPs as well, so that can help to make it inclusive to everybody. There was one more. One of the other parts is the governance and the administration. So trying to bring about the saving images, archiving, reporting, helping and making that as easy as possible, incorporating it into the induction, and ensuring that everybody is familiar with the machines. A bit like defibrillator, for example, ensuring that everybody is familiar with the machines, and nowadays some of the machines have got login, so trying to give login to the trainees. I can go on and on about various different cultures that it can be created. So yeah, it's there are certainly interventions that could be had. The other point is encouraging fellows to senior and junior fellows to come on board to specifically do point of care ultrasound. Sometimes that can be challenging, especially in peripheral hospitals compared to the central hospitals for various reasons, but certainly that can help to cultivate that culture. So it's not just one thing, there are various different things.
Yeah, definitely. I think where I worked before at St. George's, we did have they didn't call it like a work-based assessment clinic, but the one thing that I found was quite useful was that we did have dedicated days kind of set out for helping with ultrasound kind of assessments, training, teaching, which as part of as being a POCUS fellow, I would just kind of help facilitate. So work-based assessment clinics I think was great in both trying to get the trainees to engage and also have like a dedicated time, which is not pressured by the actual departmental pressures, which obviously everywhere is quite busy, and training cannot happen sometimes on the shop floor. But those sessions just adds, or at least encourages you to carry that learning onto the shop floor when you actually need to use it and integrate it with your clinical practice. But yeah, things like that was quite useful.
I think the other thing that I forgot to mention is that highlighting the cases that are clearly, which we've done on POCUSUK.org, highlighting the cases that are clearly as a part of the assessment has helped. That I think that is helpful in itself. I can go on about, I'm sure you know all this about the cases where the management and the assessment and so on is just gone completely in a different direction. So I can give a quick one. For example, somebody who you thought it was a non-STEMI turned out to be a massive P, for example. The troponin was up, there was some ischemic changes on the ECG, and everybody's scratching their head, but then they just book a bed in CCU and treat them as a non-STEMI. It turns out to be they're not progressing very well. The next day or two, they get a CTPA, they've got a massive P. And I've caught a number of these, loads of these within A&E. So and trying to highlight that in a constructive way. So it's not sort of pointing a finger at anybody. It's not to do with that. It's just to say that, look, we have our tools, but we do have this other tool that if you do learn, then that can help a lot.
Perfect. If anybody has questions, just feel free to unmute and you can ask your question. Could be related to anything. And is there some, would you say there are some kind of accreditation processes that the trainees can look into to add to their triangle of evidence? I know your triangle of evidence already mentions Farmers, FUSIC, FEEL, BSc. I find BSc quite hard because finding mentors are a bit difficult in most centers. I think you might find mentors, but I'm not sure because we've got ACCS IMT trainees now, and there are a group of trainees in acute medicine. And I haven't done farmers in field, so I don't know what your feedback regarding those two would be.
I think personally, I think it's I personally aim at the competency rather than having labels, and it's fine. You know, I'm a mentor, supervisor, trainer on a number of these, and you know, I've attended, I've taught on these courses and so on, and I think it is helpful, but there are so many cross covers within these, and it gets confusing when you're talking about different ones. And equally, there are postgraduate degrees or various other kind of CPDs that you go on. I think the key is that you've got to decide for yourself what you want to achieve, where you want to be, and once you decide that, then you can look for those and connect the dots. And one doesn't fit everything. It might be that you go to various different ones and see good practices, bad practices, and then you go to another one and you see the same thing and you join them all up. And it depends how proactive you want to be. So I don't personally recommend one or another. I don't sort of you know, I'm not one that sort of hold on to labels and stuff. I'm much more for somebody who is, as long as, for example, take echo, if the person is competent and they can talk the language and we can have a conversation about it and we understand exactly what we're talking about, I think that's the most important thing. But by all means, go and, you know, make your own mind up. I see those sort of opportunities as a way to get yourself exposed. So that's where I would leave it. I think what would be helpful to have it would be to have a generic pathway that everybody is on board with, and we get we sort of we join up the different specialities in such a way that it feels very inclusive and we help each other out. And certainly with competency-based training, this is what I've tried to get across, because as you're rotating through acute medicine or critical care or anesthetic and so on, colleagues and emergency medicine, you know, colleagues have got excellent expertise, competencies in the field of POCUS that they can teach you. And it's about using those opportunities rather than sort of chasing a certain sort of accreditation as it was. But I can equally understand why accreditations could be important. So I haven't really answered the question perhaps in the way you might have asked it, but I think hopefully I've sort of clarified that it's the journey and it's where you want to get to. That's the important one. And I think, you know, I wouldn't care if somebody is accredited in a certain things. If they can show me that they can do the scan and they understand it, you can critique it, and so on. That's what's important to me.
Yeah, I agree. And I also wanted to make a point about that the accreditation doesn't bypass the triangle of evidence and going through the competency model, because accreditation setup for doing, say, FUSIC or BSc might be different from doing it on the shop floor with a clinical patient in front of you and being the clinician making that decision. Because sometimes when accreditation processes, you're just doing the scans during the kind of gaining that accreditation. There was one question by Richard. Sorry.
And our settings are different. You know, it's you know, you got a setting whereby you got an undifferentiated patient that's just wheeled into resource. in a very kind of in a crowded environment and you know, these are really different. It's a bit like airway, you know, if you're learning to do airway, it's fine, it's great to go and learn it within the anesthetic room, even if you go to the emergency list and learning those skills and RSI and so on. But when you are in A&E and doing an airway, for example, and you know, intubating somebody, that's a completely, not completely, but rather it's different. It feels different. Pre-hospital is different. These are all different, and I think I'm more um, I'm more about thinking that yes, you can build in a safer space, and if you want it, go and learn how to do gallbladder or whatever in a department. But remember that, you know, you might be scanning, well, most of the time you're scanning in the most sort of unideal situation. The patient is not fast, the trolley is sort of put in a certain way, the lights are not off, the the height of the bed or the machine is not right. Obviously, you got to bear all that in mind, the ergonomics and the safety and so on. But you got to bear all that in mind. So it depends where you're going to be ending up working at the end of the day, and you got to learn how to do that in the most safe and effective way and efficient way.
There's a question by Richard. I think he's on a train and he's in and out. But is there a efficient way of showing competency as portfolio takes a long time to maintain? For example, level 1 ED, the amount of evidence for ultrasound is quite daunting. I think you've got the triangle of evidence on your screen. So basically, you could evidence your competencies by doing a bit of all of that.
Yeah.
And the time taken is the time taken for you to go through training. But that doesn't mean that you stop after a while of gaining a competency. The idea is you've gained a competency, either competent to that level of training or competent to do independent ultrasound, but also have to evidence ongoing, like the slide you were just going to put up, ongoing kind of evidence to show that you keep up your skill. So that would mean that as an ST1, you have got an entrustment scale 1, 2, or whatever in just doing an IV cannulation or doing an echo. But you might, and somebody else might have an entrustment scale 4, but all the onus is on both of you to show ongoing evidence of using ultrasound, and at some stages showing how you're improving or adding to your already available knowledge or skill set.
Yeah, absolutely. Remember, it's not about quantity, it's about quality. And you know, it's not about practice. Practice makes perfect. It's about good practice makes perfect. And when we are when we, you know, when you're thinking about, well, signing off, you could be signed off at level 2B competency. So that's a sign off, but that's a sign off at that level. So you still need to be supervised within the hospital. So i.e. the supervisor is within the hospital for query. So you've been signed off at that level. If you're signed off at 4, then that means you've signed off to be independent. You've reached the minimum competencies as set out, and that competency, if you look at the guidance that we've created on the RCEM website, it is not a rigid one. It is more setting out the way that we have seen it being a safe kind of practice, if you like. It's not meant to be a burden. I think what you need to please remember, everybody, is that this is like having a seed, and it's watering it, looking after it, making it into a plant, and then looking after that plant. And it's meant to be helping you. It's not about it being daunting. If you do little bits, as you're going through the training, I guarantee you will see that, by the end of each year and by the end of your training, you've got loads of evidence. I think we need to get away from this whole practice of us trying to get all the evidence in right at the end. This is not really helpful. It's not helpful for you. It's not helpful for the supervisors. It's not helpful for the ARCP, because the picture they're getting is that you're not really being proactive. You're not, you're just trying to cram everything in right at the end, and that's not really helpful. If you just set aside every week, if you set aside half an hour, literally half an hour, and I understand that now, there is this protected time, CPD time and stuff for trainees as well. If you just use that and sort of look after the portfolio. And I do appreciate the portfolio is not the most ideal as it is at the moment. For example, on Kaizen, the forms for point of care ultrasound is DOPS, and that's not, it's not, POCUS is not a procedure, is it? It's clearly an incorrect sort of form or a tool that's been used. And I had fed this back whilst I was on the committee, but the powers to be have to be working to make the portfolio a lot better, so that we've got the tools to reflect all that. And remember, if you're doing an ESLI, try to put evidence and link the evidence there. It's just about linking it. It's not about making it daunting. It's just enjoy the journey and remember that you're trying to get from A to B, but the journey is the most important part. And it's not about quantity, it's about quality. And use any opportunity that you can see. Don't think that you have to go on a certain course or a label or whatever. It could literally be a departmental half an hour teaching. It could be a video that you've watched. It could be a chapter of a book that you've read. It could be anything. It's a combination of all those that hopefully make you reach that minimum competency that you're required. And this whole idea of getting signed off, just having a one sign off at the end, triggered assessment and all that kind of stuff. I think we need to move away from that. We've inherited this culture of level 1, and we've inherited this culture of tick box exercises and so on and so forth. We need to move away from that. And why do I say that? It's because, it's not long since I finished my own training. And when you do become a consultant, remember the whole point of training is so that you become a safe consultant, and you enjoy that, and you're safe, and you can help your patients, and you can help your trainees, and you can run the department. And when you've got a crashing patient in front of you, or a trainee comes up to you and says, can you get that venous access because I don't know, it's an IVD, or is they've had chemotherapy or so on and so forth, or they're obese and so on. Don't you think it'll be embarrassing not to be at the level where you can go there and perform that? Or if you've got a crashing patient, you are able to perform a rush protocol, or if you've got a cardiac arrest, you can perform or supervise, as it might be. So think of that. Have an idea as to where you are trying to get, not just with point of care ultrasound, by the way, with anything else. It could be a chest drain. It could be procedural sedation. Just think about it. Close your eyes and think about where am I trying to get? What's the point of me doing this training? And I understand there are lots of pressures, challenges, families, and so on and so forth. I've had all that, the rotas, the night shifts, various other things that you need to fulfill. But just bear that in mind. Sometimes we just got to stop and think, what is the bigger picture? What are we trying to do? Because of course, as a consultant, you're not a finished article. And that's why CPDs and so on, and revalidations and appraisals become important as a consultant. And that's got its own downfall as well, because as I said, it is kind of open-ended, and you don't have to be particularly be groundbreaking the year after year as a consultant to pass the. Well, it's not a passing thing. It's just that it's just an exercise that you have to do to fulfill, to move to the next year and to satisfy GMC, as it were. So just enjoy the journey. Think of where you are and where you want to where you want to take. Where you are and where you want to get to, and as long as you do that, honestly, you know, it becomes seamless. You wouldn't even think about it.
Yeah, thank you so much, Nick, and thank you for also agreeing to do this. Quite useful. Lots of points there about the curriculum as well as the model. I'm quite aware of that we've gone beyond an hour, and usually my mind starts to shut off after I've spoken or read something about an hour. So if nobody has any kind of burning questions, we'll probably end it there. We will upload this video for others to obviously go through. And if anybody has any questions, just do feel free to message me, and then I can get those questions across to Nick. If you do manage to attend the RCEM ASC conference, then make sure you can attend the workshop and do say hi. I might be there with 2 case reports. Again, no surprise, they're all focus related, but they are quite interesting cases. So do join us there. And also intend to have, like, probably, if I'm able to keep up with it, 1 monthly talk, and then from today, having discussed the curriculum, we go on to more practical kind of ultrasound related topics, and I'll come up with the dates and the links closer to the day. Cool. Thank you so much for joining us, and thanks,
Thank
Nick,
you very much
for
for
just a
having
great
me.
talk.
Yeah, thank you very much for having me. Good evening. Okay, cheers. Take care.
Bye, guys. Thank you.